Imagine you were sitting in a clinic
Hmm.
and a 38-year-old woman walks in.
Right.
She has this small, maybe 2.5 centimeter swelling on the front of her neck.
Mm.
It doesn't hurt. It's not growing fast. It's just, there.
Just sitting there.
Exactly.
Yeah.
And as a medical detective, your mind immediately jumps to the single most important question in thyroid surgery.
Hmm.
Like, is this nodule trying to kill her, or is it just sitting there looking ugly?
Yeah. That is the big question.
So welcome to this deep dive. Today, we're taking a stack of your sources, surgical guidelines, clinical notes, pathology reports, and we're extracting the ultimate roadmap for navigating what's called the solitary nodular goiter.
And this is a scenario you really need to care about because it is incredibly common.
Really?
Oh, yeah. Between 4 and 7% of adults actually have a palpable thyroid nodule.
Wow, that's a lot.
It is. It's a massive chunk of the population walking around with a lump on their neck. But the stakes get infinitely higher when you look at the malignancy rate. Because between 5 and 15% of these solitary nodules are actually malignant.
Wait, really? So out of every 10 patients sitting in that clinic chair with a single nodule, 1 or 2 are walking around with cancer.
Pretty much, yeah.
Okay, let's unpack this.
Yeah.
What exactly is a solitary nodular goiter, and why is it such a notorious trap for doctors?
Well, clinically, an SNG is defined as a single, discrete, palpable swelling in an otherwise completely normal thyroid gland.
Okay,
But the key word there is clinically. I mean, it feels like a single nodule to the doctor's fingers.
right.
But the trap is that almost half of the nodules that feel solitary turn out to be multinodular goiters once you actually look closer.
So basically, our hands are liars.
Basically, yes.
We find one mouse and just, assume there aren't others in the walls until we turn on the ultrasound light.
That captures the reality perfectly, yeah. The palpable one is simply the dominant nodule.
Ah.
It's just the largest or most anterior one. So it acts like a decoy, sort of hiding a cluster of smaller nodules right behind it.
Oh, wow.
Yeah, so you can never trust clinical touch alone to define the disease state. You absolutely must combine the physical exam with radiological imaging.
Makes sense. But once we realize what we're dealing with, we're trying to answer 2 fundamental questions.
Okay.
First, is it benign or malignant? And second, is it functional or non-functional? Meaning, is this tissue actively producing thyroid hormones, or is it just taking up space?
Yeah, and we categorize them clinically as hot or cold nodules.
Hot or cold? Okay.
So hot nodules are hyperfunctioning. They're basically these rogue factories churning out hormones completely independent of the body's normal regulatory signals.
Right. And the cold ones?
Cold nodules are non-functioning.
Yeah.
And the critical insight from your clinical sources is that these two factors, malignancy and function, are inversely correlated.
Wait, inversely correlated. So if a nodule's highly active, it's actually less likely to be cancer.
Significantly less likely. Less than 1% of hot nodules are malignant.
That is wild.
It is. But the underlying biology explains this really nicely. See, highly differentiated cells that retain the complex machinery to synthesize and secrete hormones, well, they usually haven't undergone the chaotic mutations that characterize a malignancy.
Oh, I get it. They're too busy doing their job, albeit excessively, to be cancerous.
Exactly.
So the lazy nodule is the dangerous nodule.
You nailed it.
The cold, non-functioning ones carry that, 15 to 20% risk of cancer.
That is the rule of function. The lazy ones are the ones you have to relentlessly investigate.
Right. So history gives us a theoretical risk profile, but patients can be, unreliable narrators sometimes.
Oh, definitely.
We have our 38-year-old woman in front of us, and we know we're looking for a lazy, dangerous nodule. How do we figure out what this lump has been up to before she walked into the clinic?
So surgeons break the patient's history down into 4 distinct categories, or buckets of inquiry. The first is growth velocity.
Okay, speed.
Right. A nodule that slowly enlarges over several years typically suggests a benign process, but rapid growth over weeks or months. That is highly suspicious for malignancy,
Like what kind?
specifically anaplastic thyroid cancer or a lymphoma.
What if she tells us it popped up literally overnight? Like sometimes patients say they woke up and their neck was suddenly huge and painful.
Oh, yeah. So sudden painful onset almost always indicates a hemorrhage into a pre-existing benign cyst.
Yeah.
The fragile blood vessels in the cyst wall rupture, it bleeds into the closed space, and it swells rapidly.
That sounds terrifying.
It is terrifying for the patient, absolutely,
Yeah.
but biologically, it's usually benign.
So the speed of growth tells a very specific mechanical story. What's the next bucket?
Pressure symptoms. The thyroid sits in an incredibly crowded anatomical neighborhood.
Right, lots of tubes in the neck.
Exactly. So a growing mass can press against the esophagus, causing dysphagia, which is difficulty swallowing. It can press on the trachea, causing shortness of breath.
Makes sense.
But the massive red flag is a change in the patient's voice.
Hoarseness, because of the recurrent laryngeal nerve, right?
Spot on. And this raises an important question: why does the voice change? It happens because a malignant tumor has physically invaded and paralyzed that nerve, which runs right behind the thyroid and controls the vocal cords.
Wow.
Yeah. In this context, hoarseness equals cancer until proven otherwise.
That is a chilling indicator. So the third category would be toxic features, right?
Exactly.
Asking about heat intolerance, tremors, unexplained weight loss, anxiety.
Yeah.
That tells us if we're dealing with that active hot nodule we talked about earlier.
Precisely. And the final category of history is evaluating risk factors, which dramatically shifts the pretest probability.
Like what kind of factors?
We look for a history of childhood radiation to the head and neck that heavily mutates thyroid DNA. We also look for family history, particularly syndromes like MN2.
Let's clarify MN2 for a second. That stands for multiple endocrine neoplasia type 2.
Yes, it does.
And it's not just a vague family tendency, right? It's a specific genetic mutation that practically guarantees the patient will develop medullary thyroid cancer.
It is a profound genetic driver. In fact, if a patient has the URET proto-oncogene mutation associated with MEN2, their risk is so high that surgeons will often perform a prophylactic thyroidectomy on them as children.
Before a nodule even forms.
Literally before it ever forms. Furthermore, demographic factors matter too. Being under 20 or over 60 and being male inherently elevate the malignancy risk.
So a 65-year-old man with a family history of MEN2 is a totally different puzzle than our 38-year-old woman with no family history.
A completely different threat level, yeah.
Even if the bump on their neck looks identical to the naked eye.
Exactly, and that is why the history is the foundation of the investigation.
Okay, so to figure out what's actually happening, we have to physically interrogate the neck. But given that we already established our hands are liars, what can a physical exam actually prove?
Well, it provides structural context.
That-
First, you observe the patient swallowing. Why swallowing?
Because the thyroid gland is enveloped by the pretracheal fascia, a connective tissue layer that directly attaches to the larynx. So when the patient swallows, the larynx elevates, dragging the thyroid and any nodule attached to it right upward.
Okay, so if the lump doesn't move when she swallows.
Then it is likely not thyroid tissue at all. It might be a lymph node or a cyst from another structure entirely.
Got it. What about the consistency of the nodule?
Palpation still has a lot of value here. A soft, fluctuant feel suggests a fluid-filled cyst. A firm, rubbery texture suggests an adenoma, which is a benign tumor.
And the bad ones.
A hard, stony consistency implies malignancy, particularly if the nodule feels completely fixed and immobile, meaning that cancer has basically invaded the surrounding neck muscles.
Yes.
You also palpate the lateral neck for enlarged lymph nodes. Palpable cervical nodes alongside a thyroid swelling strongly point toward papillary carcinoma.
Feeling the neck makes sense, but the thyroid sits right above the chest cavity.
Yeah. If this nodule is growing downward into the thorax instead of outward, our fingers are useless. How do we spot a nodule that's hiding behind the breastbone?
We use a brilliant physiological test called Pemberton sign.
Okay, how does that work?
You instruct the patient to raise both arms above their head and just hold them there for 1 minute. If their face turns red and congested and they feel short of breath, the test is positive.
Because raising the arms forces the clavicles inward, narrowing the thoracic inlet.
You got it. The enlarged thyroid goiter is already plugging that narrow opening into the chest.
Right.
When you raise the arms, you further compress the space, completely pinching off the large jugular veins trying to drain blood from the head.
Oh.
So the venous blood backs up and the face turns distinctly plethoric or, very red.
That is a wild visual. Arms up, face turns red, boom, thoracic inlet obstruction.
Exactly.
But before we even think about fixing that in an operating room, the sources highlight this bizarre medico-legal absolute.
Yeah, and what's fascinating here is the requirement for indirect laryngoscopy before any surgery is scheduled.
So they have to look down the throat.
Yes. A surgeon must physically look down the throat and visually confirm that both vocal cords are moving normally.
To document pre-existing damage, right?
Precisely.
Because if that 38-year-old woman already has a paralyzed vocal cord from a silent invading cancer, and you don't check beforehand, she'll wake up from surgery hoarse, and you will get the blame for cutting the nerve.
Exactly. It protects the patient by staging the disease properly, and it protects the surgeon from assuming liability for damage the cancer caused.
Okay, so we have the history, we have the physical exam, but we are still largely guessing based on shadows and clues.
We need the hard data.
Right. The sources outline a modern diagnostic triad. 3 pillars. Where do we start?
We start with a simple blood test, TSH, or a thyroid-stimulating hormone. It acts as this ultimate, elegant gateway test. You see, the pituitary gland in your brain produces TSH to tell the thyroid to work.
Wait, so if the nodule is hot and producing its own rogue hormone, the brain would sense that excess hormone and shut down TSH production, right?
Exactly.
Well, low TSH means the nodule's gone rogue.
That negative feedback loop is exactly what we rely on. If the TSH is suppressed, it confirms a hyperfunctioning hot nodule.
Yeah.
And because we know hot nodules are overwhelmingly benign, that patient bypasses the cancer workup and goes straight to a radionuclide scan to map the overactive tissue.
Gotcha. What if it's normal?
But if the TSH is normal or high, it means the nodule is cold. And cold means we proceed to the second pillar of the triad, high-resolution ultrasound.
Turning on the lights. So if we are looking at the ultrasound for our 38-year-old patient, what specific pixels make a radiologist nervous?
Well, the ultrasound isn't just looking at size. It's actually analyzing the architectural density of the tissue. A key red flag is a hypoechoic appearance.
Meaning it looks darker than the surrounding muscle on the screen. Why does that matter?
Because sound waves travel differently through different densities. A hypoechoic nodule is highly cellular with very little fluid, meaning it absorbs the sound waves rather than bouncing them back to the probe.
Oh, I see.
And cancers are densely packed with cells. Another major red flag is microcalcifications.
The little calcium bits.
Yeah, these are tiny calcium deposits. They often represent psammoma bodies, which are dead, calcified cells typical of papillary thyroid cancer.
Wow.
They act like little rocks, reflecting the ultrasound waves so strongly that they cast these dark acoustic shadows underneath them.
And all these visual clues get fed into an algorithm called TIRADS, right? The
Yeah.
Thyroid Imaging Reporting and Data System,
Exactly.
which scores the nodule from 1 to 5 based on its suspicion level.
Okay.
Like a TR3 gets biopsied if it's over 2.5 centimeters.
Right.
TR4 if it's over 1.5, and TR5 if it's just over 1 centimeter. But if TIRADS is so sophisticated at analyzing acoustic shadows and cellular density, why do we need the third pillar? Like, why stick a needle into her neck?
Because ultrasound only gives you shadows and shapes. It provides probability, not pathology.
Yeah.
Fine needle aspiration cytology, or FNAC, gives you the actual cells. It is the gold standard.
Okay, so the actual physical cells.
Right. A pathologist looks at the extracted cells under a microscope and categorizes them using the Bethesda system, which is this brilliant 6-tier framework.
Right. So what does this all mean? The Bethesda system seems to be the linchpin of this entire clinical pathway.
It absolutely is.
Tier 1 means unsatisfactory. You just didn't get enough cells and have to poke again.
Yes.
Tier 2 is benign, so we just observe her.
Right.
Tier 3 is atypia, meaning the cells look weird, but not definitively cancerous, prompting either a repeat biopsy or maybe taking out half the thyroid to be safe. But Tier 4 is where the logic gets tricky, doesn't it?
Yeah, Tier 4 is follicular neoplasm. This is a notoriously frustrating category for surgeons.
Wait, why can't the cytology tell us if it's cancer? We literally have the cells under a microscope.
Because follicular cancer cells look absolutely identical to benign follicular adenoma cells.
Identical.
Identical. The defining feature of a follicular malignancy isn't the shape of the cell itself, it's behavioral.
How so?
It's about whether those cells have physically broken through the thick fibrous capsule surrounding the tumor, or if they've invaded the neighboring blood vessels.
Oh, and you can't see the tumor capsule through a tiny needle core.
No, you can't.
You're just sucking out the contents of the balloon, not looking at the skin of the balloon.
That is exactly the problem. Therefore, a Bethesda 4 diagnosis dictates a specific surgical action, a diagnostic hemothyroidectomy.
So you have to cut.
Yes, you have to surgically remove half the thyroid gland just to hand the intact tumor to the pathologist so they can examine the capsule borders.
That is wild. And then Tier 5 is suspicious for malignancy, and Tier 6 is confirmed malignancy, both of which route the patient for a total thyroidectomy.
Yes.
The genius of the Bethesda system is that it isn't just a list of diagnoses, It forces a translation. It converts a fuzzy biological observation into a rigid binary surgical action plan.
That is the beauty of algorithmic medicine. It removes the guesswork from the surgical decision. The number tells the surgeon exactly what operation to book.
Let's open up the bag of actual diagnoses, though.
Hmm.
When that FNAC comes back, what are the things this nodule could actually be?
Well, the vast majority of the time, it's benign and non-neoplastic. The most common diagnosis is a simple colloid nodule, which is essentially just a harmless, stagnant pool of protein.
Okay, that's good news.
Then you have benign neoplasms, like the follicular adenoma we just discussed. And finally, you have the malignancies.
Right. And within the cancers, papillary carcinoma dominates, making up about 80% of cases. Follicular carcinoma sits around 15%, medullary at 5%. And then there is anaplastic cancer at 1 to 2%. Why is anaplastic so feared in the literature?
Because anaplastic thyroid cancer is one of the most aggressive and universally fatal solid tumors known to medicine.
Universally fatal.
Pretty much. The cells have completely dedifferentiated. They basically forget how to be thyroid cells and only know how to multiply and invade.
Oh, that sounds awful.
It is. It typically presents in elderly patients as a massive, rapidly expanding neck mass that quickly suffocates them by crushing the airway.
Man. Let's step back for a moment. What if we took that toxic detour earlier in our diagnostic triad?
Sure.
What if her TSH was low and it was a hot nodule?
Okay, so if a solitary nodule is autonomously producing excess hormone, we call it Plummer's disease.
Plummer's disease, got it.
You have 3 treatment options: antithyroid drugs to block hormone synthesis, radioactive iodine to selectively burn out the overactive tissue, or surgery to cut it out.
But the sources contain a massive warning label here. They explicitly state you must never operate on a thyrotoxic patient electively. Why is that?
Because you risk triggering a thyroid storm.
A storm.
Yeah. If you cut into a thyroid gland that is highly active and engorged with stored hormones, the physical manipulation of the surgery, combined with the stress of anesthesia, causes a massive uncontrollable dump of catecholamines and thyroid hormones directly into the bloodstream.
Which leads to cardiovascular collapse.
Total systemic overload. The patient develops hyperpyrexia, which is a severely high fever, extreme tachycardia, arrhythmias, and eventually coma.
Wow.
The mortality rate of a thyroid storm is up to 30%, even in a modern ICU.
So you have to cool the engine down before you open the hood.
Precisely.
You must make them euthyroid, bring their hormone levels back to normal using beta blockers and antithyroid drugs over several weeks before you ever pick up a scalpel.
It is a non-negotiable rule of surgical safety.
Let's talk about that surgery. When our 38-year-old woman is finally wheeled into the OR, how do surgeons choose between a hemithyroidectomy and a total thyroidectomy?
It's a delicate balance of risk versus cure. A hemithyroidectomy removes one lobe and the central bridge, the isthmus.
Okay.
It is utilized for unilateral benign disease, or that Bethesda 4 category. By leaving the other lobe intact, you spare the parathyroid glands on that side, and the patient often produces enough natural hormone to avoid lifelong levothyroxine pills.
And a total thyroidectomy, removing the whole gland, is reserved for confirmed malignancies, massive goiters causing severe compression, or bilateral disease.
Exactly.
But the neck is such a crowded area. I used to think of it like diffusing a bomb, cutting the exact right wires. But based on the anatomy in these sources, it's not really like cutting wires at all.
Really? How would you describe it?
So removing a thyroid isn't like removing a discrete organ like a gallbladder. It's more like trying to carefully unwrap vines from a trellis without snapping any of the structural wood beneath it.
That's a great analogy.
Right. The wood being the incredibly delicate nerves and parathyroid glands embedded in and around the thyroid tissue.
Yeah. If we connect this to the bigger picture, mastering that trellis anatomy is what separates good surgeons from dangerous ones.
Very true.
There are 3 specific structures every surgeon absolutely must protect. First, the recurrent laryngeal nerve we mentioned earlier, sitting in the tracheo-esophageal groove.
Okay, the voice nerve.
Right. If you sever it on one side, the patient loses their voice. If you mistakenly sever both vocal cords paralyze in the closed position, instantly blocking the airway.
A catastrophic emergency. Structure number 2.
The external branch of the superior laryngeal nerve. This nerve acts as the tensioner for the vocal cords.
What does that mean in practice?
Well, if you damage it, the patient's voice might sound normal in regular conversation, but they will entirely lose their high pitch. They cannot project their voice or hit high notes.
Oh, man. So it's a devastating complication for a singer, a teacher, or a public speaker.
Absolutely devastating. And the third structures to protect are the four tiny parathyroid glands.
Right, the calcium regulators.
These glands, often just the size of a grain of rice, control the calcium levels in your blood. Their challenge is their incredibly fragile end artery blood supply.
So they're easy to kill.
Very. You can leave the gland perfectly intact, but if you accidentally coagulate the microscopic blood vessel feeding it, the gland dies. You have to handle them like wet tissue paper.
And if the surgeon realizes they just devascularized one of those parathyroid glands, what do?
They perform an immediate autotransplantation.
Wait, what is that?
They literally mince the dying gland into tiny pieces and implant them into the fibers of the sternocleidomastoid muscle in the neck.
No way.
Yes. The muscle's rich blood supply will coax the parathyroid tissue back to life, saving the patient's calcium function.
You plant them in a neck muscle to grow like seeds. That is wild.
It is amazing, isn't it?
It totally reinforces the core surgical maxim of the thyroid. Slow surgery is safe surgery.
Always.
But even going slowly, what happens when things go wrong post-operatively?
We categorize complications sequentially. The immediate nightmare occurring within the first 24 hours is reactionary hemorrhage.
Okay.
An artery slips its tie and begins pumping blood into the closed space of the neck wound.
And because the neck is encased in tight fascia, that blood has nowhere to go. It forms a tense hematoma that pushes backward, physically crushing the flexible trachea.
Exactly. It rapidly asphyxiates the patient. There's no time to transport them back to the operating room.
So what happens?
The surgical resident must sprint to the bedside, use a suture cutter to open the neck wound right there in the recovery room, and manually evacuate the blood clots to allow the trachea to spring open so the patient can breathe.
Oh my God.
Yeah, that is why a sterile dressing tray with a suture cutter is absolutely non-negotiable at the bedside for the first 24 hours.
That is intense. And early complications in the following days.
We monitor for hypocalcemia. If those parathyroid glands were bruised and temporarily stop working, blood calcium drops.
And they get cramps.
Yes, the patient experiences numbness around the lips and severe facial spasms. We check their serum calcium rigorously on post-op days 1 and 2 to supplement them if necessary.
Got it. And the late complications.
The main late complication is simply hypothyroidism, requiring a daily levothyroxine pill for the rest of their life.
Okay, we have covered a massive amount of ground. From the physical exam to the FNAC needle to the bedside suture cutter. What is the ultimate takeaway for you, the listener, to organize all this complex pathophysiology?
I'd say think of the solitary nodular goiter in 3 cohesive layers.
Okay, 3 layers.
Layer 1 is the question. Every single nodule presents a binary threat assessment. Is it benign or is it malignant?
Right.
Layer 2 is the triad. TSH to determine function, ultrasound to assess structure, and FNAC to analyze the cells. That is the pathway to answering the question.
Layer 3.
Layer 3 is the decision. The Bethesda category translates the cytology directly into the specific surgical operation.
Here's where it gets really interesting. Think about how incredible medical frameworks like TRADS and the Bethesda system truly are. They're not just diagnostic tools. They are universal languages.
They absolutely are. They standardize human judgment.
Exactly. A doctor in Tokyo and a doctor in Toronto can look at the exact same fuzzy acoustic shadows on an ultrasound. They can speak a simple number from 1 to 6 and immediately align on whether to just observe a patient or wheel them into the operating room.
It's pretty amazing.
It proves that the greatest advancements in medicine aren't always new surgical robots or new lasers or new chemical compounds. Sometimes they are simply better frameworks for human beings to organize complex biological information.
Very well said.
So the next time you hear about a solitary nodule, remember that 38-year-old woman sitting in the clinic. The diagnostic muddy waters are deep, but we have a map. And it all starts by figuring out if that little bump on her neck is just sitting there being lazy, or if it is secretly dangerous.